Okay, welcome everyone. My name is Rich Ailes, and on behalf of the Concord Quarter Working Group on Aging Concerns, I'm happy to invite you to our presentation on who needs a POLST. Just a little background on our group. This working group has been in existence since 2017, formed out of a group of Quakers attending meetings that exist in parts of Delaware County, Chester County, and northern Delaware. We meet several times a year with one purpose, among others, is to bring to the Quaker community and to the community at large programs that are of interest to aging adults. You can find out more about us by going to concordquarter.org and look for us under the heading up in the titles under Aging Concerns. I'm really excited about having this program. We're bringing together three participants in the medical field who have, I think you'll find some pretty interesting angles on PULSE, which is the physician's order for life-sustaining treatment. Dr. Maria, I'm sorry, I don't know. Dr. Maria D'Souza is a geriatrician with expertise in dementia care and caregiver support. She's a graduate of the University of Missouri, Kansas City School of Medicine, with residency training in internal medicine at the University of Washington. Then she did a 3-year geriatrics fellowship at Duke University and a master's of public health degree at the University of North Carolina in Chapel Hill. She currently leads the Compass Dementia Care Program in Wilmington. And that's Dr. D'Souza up there. There she is. Erica Blanco Sacchi is an experienced registered nurse with over a decade of clinical experience in emergency care, critical transport, and nursing education. Currently serving as a flight ground transport RN with Penn-Star Flight Team, Erica plays a key role in managing critically ill patients. Erica has held staff nursing roles at Penn Presbyterian Medical Center, Thomas Jefferson University Hospital, and Riddle Hospital. And Thomas Vogelsgang is a flight paramedic with over 15 years of experience in emergency medical services and critical care transport, currently serving with Penn-Star Flight at the University of Pennsylvania Health System. He provides advanced intercity air and ground transport for critically ill patients throughout the tri-state area. His background includes critical care roles with Christiana Care and the Temple Transport Team. And Tom is up there walking around because Tom is on active duty tonight. So he might be called away to get into a helicopter. So if he suddenly disappears, you'll know what's happening. Well, Dr. D'Souza and Tom and Erica, thank you very much for being here. This is going to be a very important program. This will be great. So our format is as follows. Dr. D'Souza will give us a brief description of PULSE, DNR, and advanced directives. So we get a context for how this PULSE document fits in with those other critical documents and clear up what some of us may have are misconceptions. Then Tom will speak about his experiences as a paramedic, which should bring us some insight into what a paramedic goes through when faced with a life-threatening situation, sometimes when that person is unconscious. Then Erica will talk about her experience in the emergency room and other areas of hospital care where PULSE and advanced directives come into play. Erica has told us that she will be rather graphic in her explanations of what goes on in the ER during resuscitation episodes, and I imagine other places too. In our planning session that we had last week, we thought that this was perfectly appropriate for us to understand what goes on because it's quite different than what we normally see on medical shows on TV. And then Dr. D'Souza will finish up with more details of her work with aging adults and the PULSE situation with some online presentations about filling out the PULSE form and an explanation of how that form would travel with us through our own hospital experiences. Panelists feel comfortable taking questions during their presentation. So if you have a question and want to interrupt the speaker, raise your electronic hand. For Windows machines, I believe it's the heart icon. And for Mac machines, it's the hand icon in the toolbar. So when you raise your hand, for me, you'll flip up to the upper left part of the screen, and I'll be able to unmute you and let you ask your question. And also, if you want to use the chat, you can send it to the CQM coordinator, our big coordinator up there wearing the baseball cap, is Chris Stern. Yes. And if you don't want to speak, but rather put a question in the chat, you can do that with him. So yeah, okay, I'm going to go impromptu here. It just seems to me that it's really appropriate to have two people with us tonight who are kind of, on the front lines, who have to deal with, people in emergency situations, and probably a lot of times where they have to make decisions without the advantage of having a POLST or an advanced directive. So I'm looking forward to that, and I'm looking forward to Dr. D'Souza's presentation on how to fill out a POLST and everything. So with that, Dr. D'Souza, if you want to start.
Yeah, absolutely. Rich, thank you so much for the introductions and to the working group for the invitation to speak. I know all three of us are incredibly passionate about this topic, and we feel fortunate to have the opportunity to share our expertise in the hopes of being helpful and shedding light on things. So I'm going to share my screen as I've been tasked with providing an overview of the terminology. And let's see here. I know it was suggested to me that I try to send these out. There we go. I was like, oh no, I'm having a glitch, but I'm not. Let me put this in presenter mode. So I'm just going to, very briefly try to define some terminology here before turning things over to Tom. So advanced directives are completed by individuals for themselves, sometimes with an attorney, but it's not required, but it doesn't involve a medical professional. And it is a legal document that is relevant to future preferences that are typically specifying preferences at the very end of life. The language typically speaks to if I am imminently dying, or if I'm permanently unconscious or in a vegetative state, what interventions does a person want or not want? And by the way, just as an aside, an advance directive has two components: the healthcare power of attorney, where you specify who you would want making decisions on your behalf if you couldn't speak for yourself, and then the living will, which is the part where these preferences are specified. Around CPR, life support, it's recommended that all adults, even college students, have a document of this nature in place. A POLST form, on the other hand, is active in the present. It is medical orders that are completed by a medical provider in partnership with the patient to translate patient wishes into medical orders that instruct medical teams about what to do for a seriously ill person when they can't speak for themselves. And I'll talk more about this later, but the POLST form, again, is recommended to be completed with individuals who have chronic or serious illness. And it's not a one and done document. It's something that's intended to be reviewed and updated periodically as the person's health status changes. And then finally, another term that gets thrown around and brought up in discussions of this nature are DNR orders. And I wanted to clarify that that's not something that individuals would need to pursue completing for themselves. A DNR order is a medical order that's written and implemented by healthcare providers in a healthcare setting. Again, typically based on what the advanced directive specifies when someone is near the end of life, in discussion with the patient and or their loved ones, a healthcare provider writes a DNR order. And POLST, again, stands for Physician Orders for Life-Sustaining Treatment. There are different variations of this in every state. In Delaware, it's actually called a DMOST form, Delaware Medical Orders for Scope of Treatment. And there's this movement started, I don't know, several years ago, maybe a little over a decade or two ago. There's a lot of resources online. I'll include some of those when I speak later. But very, very helpful resources out there. I think that's all the terminology I need to cover before I turn things over to Tom, unless there are any questions right now. And I guess real quick, one other thing I did create on a slide here. Oops. These are what the forms look like. The Pennsylvania POLST is on the left. The Delaware DMOST form is on the right. And again, I'll circle back to this. But before I turn things over to Tom, just to briefly at least outline what treatments are listed on a POLST form. Three big things: whether or not you want CPR performed, what kind of care you want, full or intensive care, selective or comfort-focused treatments, and what level of medically assisted nutrition you would want. So I will stop my screen share and turn things over to Tom to talk about what happens on the ground when 911 is called. And over to you, Tom.
Okay, great. I'm really excited about this. I wish more people would have these conversations because in the 911 world, we're always an unexpected guest and no one's ever prepared. If you have all of these paperwork filled out and squared away to have these plans in place, mostly what I could say about them is keep them handy somewhere where you can find them. Hang them on your refrigerator, have your family know what your wishes are, and make sure just everybody is on the same page, because most of the time people aren't necessarily expected to emergency to happen. So yeah, this just preparing is key. What I wanted to touch base on outside of this is what to expect when the ambulance actually shows up to your house. When we talked about this meeting, there was a lot of questions on who shows up when I call 911 and things like that. If you guys want to know all about that, I'd be happy to tell you. Like if you call 911, depending on where you live, you might get an EMT. You may get a paramedic. It depends on honestly where you live and what the severity of your injury is. How I had a bunch of notes, and I wasn't expecting to do this in the front seat of an ambulance, and I'm sorry, I'm kind of just going with it. So bear with me a bit. So when you call 911, we show up to your house. There's some things to think about. So like your house number, for instance, being lit and we can see it, that would be wonderful. And say if you're hurt on the floor or something like that, and you can't get to the door, if you had like a T box or something like that, that you could tell the 911 dispatcher on how to get into your house because of unable to get to the door. It's thousands of dollars, and I end up breaking down the door. As far as finding, does anybody have any questions right now about? I feel like describing what we do in the house is very helpful in these situations.
Tom, I think it's helpful to, talk about your work and what a paramedic does, what an EMT does, and
Okay.
Perhaps you've been faced with situations where people are unconscious and you're not sure
Yep.
what to do with a pulse.
So
And there was
basically, the EMT and the paramedic.
There was a quick question from Leslie Friedman about the difference between an EMT and a paramedic.
Okay, an EMT goes to school for about 3 months. They learn very, very basic life, like CPR, stopping bleeding, taking vital signs, while a paramedic goes to school for 2 years and can give a lot of different medications and read EKGs and has a much broader scope of practice in order to help someone in need. Like if you're unconscious, a paramedic would always come to your house to assist you. Um, so, sorry, I'm having internet issues. Um, so yeah, the when I had notes, I'm sorry about this. So it's like if you're unconscious at home, and someone calls 911, we're obviously going to get there and assess your level of consciousness. Um, whether or not you're breathing, whether or not you have a pulse, depending on what you have in your paperwork for your demos and things like that, it will depend on what we might necessarily do or not do to you. If you don't have that paperwork handy, we would go through and do everything for you, like go through a full line of resuscitation efforts, which CPR, intubation, which is putting a breathing tube down your throat, and pretty much anything we can do to get you back to life.
Tom, a question.
Yes,
Again,
sir.
I'll probably ask this of Erica. Are you legally bound to, if there's no paperwork involved, to do whatever you can to resuscitate somebody?
Yes, we do whatever we can to resuscitate. That being said, a lot of times people aren't aware. We will, if you're in a cardiac arrest and your heart's not beating and you're not breathing, we will try everything we can. And some people aren't aware of this, but if there's nothing else we can do for you and we can't get your breathing again, your heart beating again, we might actually end up not transporting you to the hospital, because as a paramedic, we can basically do everything that the emergency room does in a cardiac arrest situation. So people are always surprised to hear, like, we tried everything we can, there's nothing we can do, we're going to stop this effort right now.
So I have on my notes some criteria that we use for termination that I'm sure you also use in the field. So I'll go over that as well.
Okay, that's great. For criteria of termination in the field, it's basically, we tried everything we have and nothing is changing and we can't get your heart to beat again. We make a phone call to the doctor and we have a conversation of, we've been working on this patient for a really long time. This is their issue. Nothing's changing, and it's a collaborative effort between us and the doctor to make those decisions. And we obviously talk to the family as well in the situation, because we want everybody involved that we can.
And just to clarify, when we say termination, we mean termination of efforts on our part to resuscitate this person.
Yeah, and resuscitate meaning CPR, everything, defibrillation, putting in a breathing tube. Does anybody have any questions?
What about older adults as opposed to younger folks? Are you looking for a POLST or a DNR statement with older folks, or in any situation?
Generally, we would look for it with older folks, and like people that have these paperwork usually are up on it. Usually they have it and the family is aware of it. Younger folks generally don't have it, and it's something they don't think about because you're younger, you're not expecting these situations. There generally isn't much difference. The resuscitation is still the same. So, yeah. My suggestions, I have plenty of suggestions on how to prepare for EMS to come to your house. And like I said, with the door locks, putting dogs away, things like that. And a lot of the times that we go to people's homes, some of these things are preventable falls, things like that, like moving area rugs and things like that out of the house, having handles in your showers, things like that. I know it's a little off topic for what we're talking about today, but as EMS goes, you have the paperwork, we're going to follow it.
Can I ask some questions
Sheila,
related to
Sheila
that?
has a question. Yes, go
Sure,
ahead.
yeah.
So I'm a designer and I do aging in place design sometimes, and I'm trying to do more. And is there anything that, other than the things you've said, that lighting the house number and having a key available for when you are coming, what are the most helpful things that a house can have?
Your medication lists and things like that, handy. If you have children in the house, having someone able to take care of them, like a neighbor, something like that. Everybody says their dogs are really nice and they won't bother you, but dogs are completely different in an emergency. We really appreciate if you put them in another room before we get there.
Thank you.
Yeah.
Yeah, this is really helpful, Tom, and actually it would be great to get a document that we could pass out for people about this, because I mean these are things that I never would consider. Um, Lynn asks, can you honor an advance directive or a living will as a paramedic?
For the most part, yeah. I would definitely call. It's conversation with the doctor. At the end of the day, I still have to call the medical command doctor on the phone and explain them the situation, and we honor everything as best as we can. There's always some sort. There's never a cut and dry in my industry. There's just no black and white. There's always outliers, and sometimes the outliers, we may have to go down a different road. Like I said, it's very important for everybody in the family to be on the same page of what your wishes are, because I've been in situations where this is the patient's wishes and they have all the paperwork, and then the family's like, nope, I want everything done now. And it's nerve-wracking and scary, and they're just trying to do what they think is right for them in
Okay.
that situation.
Another question, Leslie, go ahead.
I'm actually looking at the Pennsylvania POLST form online, and in section B, assuming I'm not in cardio arrest, it gives choices for medical interventions if I have a pulse and or I'm breathing. But those choices are quite different, and it would depend on, if I know I'm going to be a quadriplegic, my answer is going to be one thing. If I know I'm, I don't know, I'm in a bad accident and I have, like 10 broken bones, it's going to be a different answer. And so I'm wondering how that difference in, those differences in situations are reflected or can be.
Well, generally with like the paperwork filled out, I mean, for the most part, there's usually an underlying condition. Like if you were in a car accident or something like that, chances are you wouldn't have the paperwork there, and we would do everything we could do to stabilize you to get you to the hospital. If you had that paperwork there, that's where Erica and the hospital team would come in and talk about those situations.
I was going to say that's actually a really great segue into hospital care. If anybody else doesn't have any questions about pre-hospital care.
No, I think that's a good segue. Erica, go ahead.
So again, my name is Erica Saki. I'm actually Rich Ailes' nephew's wife. So we've known each other, and hi Shirley, we've known each other for quite some time. So let me just kind of back up a step, and Leslie, I'll get to your question, I think, in a little bit of time. But I just kind of wanted to go over a couple of nitty-gritty details, like when somebody presents to the emergency department in a cardiac arrest. It happens with relative frequency that EMS will go to a person's house. They either don't have a POLST, or they couldn't find it, or there was an agreement on it, or something, and the paramedics are doing their work. And because of the circumstances of what happened, the circumstances of the cardiac arrest, maybe somebody saw them go down. So a witnessed cardiac arrest as opposed to an unwitnessed cardiac arrest, where somebody was maybe like found in their bed without a pulse and you have no idea how long that's been going on for. A witnessed cardiac arrest is much more likely to be transported to the hospital, even if they don't have a heartbeat, because there's more of a chance of getting it back. Obviously, that's somebody who does not have a pulse or is not vocal with their family about their wishes to not be resuscitated. So when they arrive to the emergency department, they typically will have CPR in progress, as well as what we call an advanced airway, which is a breathing tube. There's a couple different types, but usually when a medic like Tom shows up, it's the good type that's going to stay in. And that is giving breaths artificially. And I think we'll start with that. So a breathing tube is something that people tend to gloss over, to not really think about, because it's something that happens, again, with relative frequency in non-emergent situations as well. So if any of you have ever had surgery or, even just sometimes short procedures, you'll get a breathing tube for a very short period of time. The circumstances under which those tubes are put in really makes a difference. So when you're having surgery, I'm sure you all remember you had a discussion with the anesthesiologist. They ask you about your teeth. Do you snore? Open your mouth. What does it look like? So they have a plan for how to get this breathing tube in and manage you very comfortably. And if you're already very ill, let's say you have something like COPD or emphysema or lung cancer, then they simply will not do your elective surgery because it's not safe to breathe for you artificially. In a situation like a cardiac arrest, when they put the tube in, it's fast because that's all that matters. The tube goes in, and all that matters is that oxygen starts flowing into your lungs so that we can start to circulate some oxygenated blood into your body. That's typically not, it's not comfortable, but you're not going to notice it, but it can do some damage. It can do damage to teeth. It can do damage to your mouth, to your trachea. Sometimes the bag gets overinflated. You can overinflate lungs and cause some damage to the lungs. It's not an ideal airway, we would say. And then in addition to that, you're obviously undergoing CPR. And I apologize, this is where it might get a little bit graphic, but I think it is really important that you guys understand exactly what CPR is. Because on TV, maybe even on the pit, I don't know, I can't watch it. I don't watch the pit. They're doing it to actors, and so they're not actually doing CPR. CPR are compressions that are 1/3 the depth of your chest, which means that your whole rib cage gets pushed down by 1/3. And especially if you're a little bit older, if you maybe have osteoporosis, those ribs break pretty easily. And when that happens, it's not just uncomfortable if you do regain consciousness, but it can cause problems down the line, like air in your chest cavity where it's not supposed to be, called a pneumothorax, where you would then need a chest tube. It can cause bruising on your lungs and cause them to fill with blood and cause breathing problems down the line. Again, if you do survive the cardiac arrest, it can cause extreme pain, which even if you don't come back fully to consciousness, your body may be aware of that extreme pain in your chest and in your back. So CPR is not at all benign. It's a very invasive procedure and something that we can do for upwards of an hour, maybe more, if we're getting some small signs of life or we're not able to meet all of our termination of efforts criteria, which I know Tom glossed over a little bit. And again, it's not a hard and fast definition for us in the emergency department either. It is done in conjunction with family. It's done in conjunction with, obviously, medical personnel as our emergency room physicians. And it tends to be a group decision based on everybody's input. So without these POLST forms, we do everything that we need to do, which includes, like I said, the breathing tube and the CPR, but also includes putting in not just normal IV lines, because when you're in cardiac arrest, your blood vessels are very, very small, very difficult to find, and very difficult to get to. So we need to put medications directly into your bloodstream. The way we do that is we put a needle directly into the bone, either into your shoulder or in your leg, to administer medications that way. And it's called an IO, or intraosseous catheter. And again, not a benign thing. And if those efforts continue, we may put in something called a central line, which is a large, large gauge IV that goes either in your neck, in your chest, or in your groin, to have access to really large gauge blood vessels so we can administer those medications. And all of that, like I said, leads to potential for infection, leads to definitely pain and discomfort on the other end, if that's something that you're able to feel neurologically. And it's, all in all, it's a pretty brutal thing. Do I have any questions about any of that? That's sort of the nitty-gritty.
I'd just like to add how brutal it can be. A lot of times I've started CPR on a family member in their home, and the family's like, just stop. I don't want my loved one to suffer anymore. Just, that's how brutal it is. It's not like TV.
Mm-hmm. Pam has a question. Pam Churchio?
Needs to unmute.
Yeah, Pam, you need to unmute. Well, Pam, okay, there she goes. Good.
The POLST in the original slide was described as something for individuals with chronic or serious illness. But are you recommending it for everybody? Because like me and all my family members have the Advanced Healthcare Directive, and it's pretty specific in a living will. And so that's a great message. Pull that out if the EMTs are coming. I'm sure that will cover some of this. But why would anybody have a POLST if they weren't near the end and in chronic situations? Are we going over the details of these things so that we understand if we get to a chronic and severe illness that we don't want those things because they're so horrific? But why would anybody have a POLST if they weren't in a chronic, serious end of life situation?
Speak to that briefly, and you're exactly right. It's to illuminate as you approach that scenario, or deal with it with loved ones, etc., so that you'd be prepared and know that that is a vehicle, that a POLST is available to you as a vehicle to operationalize your preferences. It's not typical or recommended for people who are healthy to have a POLST form, because survival and outcomes are good when CPR is administered to healthy people, but they are poor, and I'll provide statistics later.
Actually, I have some out of hospital
great
survivability statistics as well.
Great.
Does that answer your question?
Yeah, we got to unmute. Yes, thank you, because I'm a planner and I'm like, well, I don't need a POLST yet. But it's good to pay attention if you have aging friends or aging parents, or someone who's in end stage ALS or end stage, cancer, or going on hospice. Those are sort of the points at which you would recommend creating this. Yes.
Exactly.
Okay.
Exactly.
Yeah, I would
And
imagine also, Dr. D'Souza, doesn't an advanced directive, if that's available, come into play in these situations where a POLST wouldn't be necessary?
Not exactly. In an emergency situation, where Tom and his colleagues are faced with what to do, if this is someone for whom this is a new, unexpected event, that's different from when someone is in a, they've been progressing towards an end of life situation and it's very clear that they're imminently dying or that they're not going to recover, if that makes sense.
Right, right. But what this lady just asked was, what if she isn't in that situation, but is in a situation where she may come out of something with being a quadriplegic or, having a very crippling situation, and she would prefer just for people to let her go, then an advance directive in a hospital situation might be appropriate, right?
Correct.
Okay.
Correct.
And Erica, do you guys look for that advance directive, or does that come after the ER?
So that typically comes after the emergency phase when you get more into the critical care or intensive care phase. So let's say you do get a heartbeat back, something we call ROSC, which is return of spontaneous circulation, meaning your heart starts beating again. Then you move out of the emergency department and into the ICU.
Hmm.
And those are conversations that you would have with the ICU.
Hmm.
So, prognostication or, trying to figure out exactly what this is going to look like after your cardiac arrest is something that's very individual and it's very much based on what happened, what your labs look like, how bad this got, how much damage your heart sustained, how, what actually was the root of all of this. Will all sincerely color your prognostication for the future. So
Hmm.
what that recovery looks like, and obviously what meaningful recovery means to you is very different than what it means to anybody else. So making sure that your family knows
Mm.
150% and is very, very clear on what your boundaries are in terms of what a meaningful life is, so that they can comfortably and confidently say, my mom would not have wanted this, or my sister would not have wanted to live like this. Being able to spell that out, both in that legal document as well as just sort of verbally with your family, is so important.
Great. Now, Gary has been patient. Gary Johnson has a question. Gary?
Yeah, I used to teach in a medical setting, and one of the interesting studies I would cite to our residents was talking to physicians about whether or not they wanted to have cancer treatment for themselves, chemotherapy. And almost universally, physicians would say, no, it's not good. I'm not gonna end up where I want to be. I guess I would have the same kind of question. I'm an 80-year-old, in tolerable health, but not out running marathons, and I wonder what the likelihood of my surviving cardiac resuscitation relatively intact would be. What are the odds when you're 80 years old and that happens?
Well, you know what, Gary? I think you maybe are cheating and looking at my notes. That's exactly what I have in front of me. I was thinking about this talk a little bit earlier today, and I decided to look up some statistics on in hospital and out of hospital cardiac arrest. So obviously those are
Okay.
very separate things.
Hmm.
In hospital cardiac arrest is typically when people are already ill, they're already in the hospital. So those are
Right.
not super relevant to the POLST discussion. But the out of hospital cardiac arrest statistics were very interesting. So the study that I looked at broke it up into three age categories. There was the working age group, which I kind of discarded because we're looking at, in this discussion, we're looking at more senior ages. So they described early senior as 66 to 80 years old. And for out of hospital CPR, I'm sorry, for out of hospital cardiac arrest, the 30-day mortality rate in the 66 to 80-year-old group was 5.6%. That was the 5.6% made it 30 days, and
Right.
5.0% made it to 1 year.
Okay.
In the late senior category, which was over 80 years, there was 5% survivability at 30 days and 1.3% survivability at 1 year.
Hmm.
Um, So there has been improvements in cardiac arrest care over the last 10 years, actually pretty significant improvements, but those improvements in survival rates have not carried through to the 80 plus category. So everybody under 80 has had marginal improvements in their out of hospital cardiac arrest rates, but over 80 has stayed relatively low. So if you need some numbers to help kind of guide your goals of care, that's one of them.
So, Erica, is that in hospital CPR that
To clarify, that is out of hospital
out
CPR.
of hospital? What
That is
about in
out of
hospital?
hospital. I actually didn't write it down.
Okay.
We're talking about in hospital. In hospital includes people who are chronically ill, people who are there for surgery. So I didn't think it was as relevant. But the out of hospital is the people that Tom would initially see and then would come to us in the emergency department.
Gotcha. Okay, that's fine. All right. Continue.
There's another question in the chat.
Yeah, go ahead, Chris. I don't see it.
At what point in the emergency care do medical professionals look for forms? In the home, I assume the responsibility is on other persons present to know about them and where they are. Is there a way for the hospital to have documentation on file that would be accessible?
Well, isn't the post form supposed to follow if there is one on the person, right? It's supposed to follow the person. Is that right,
Yes,
Doctor?
that would be like what Tom was discussing, something that you would want to keep on your fridge or on your door, or somewhere very, very visible, or obviously have whoever is going to be in your home, maybe letting medics in or taking care of your dog or whoever, would be able to make that available to the field team that comes in, so the EMTs or the paramedics, and then they would carry that into the emergency department where we would use it to guide our care efforts, in conjunction, obviously, with your primary point of care or your next of kin.
So, Erica, I have a question, and maybe for Tom too. What complicates your work in these kinds of situations? Is it family members who are pulling against each other and wanting you to do everything when there might not be no hope, or what is the thing that makes you guys, lose sleep? Yeah.
Like I said, we're way ahead of the game just having these conversations. People don't like having these difficult conversations. You have to have these conversations with your family members to know what's going on, to express what you want and what your needs are. Like I said, no one wakes up in the morning and, I'm going to call 911 today and have an emergency. So it's full of emotion. They don't know what to do. All I can say is have the conversation. The families, loved ones, which is understandable because they care. It's the most difficult portion of any resuscitation effort. The medical side of things, we have all the protocols, everything we can manage that, but the emotion is the hardest part to manage in these situations.
Yeah, I think I am in absolute agreement with Tom. I think we see it play out far too often where, we have maybe even not a POLST form, but an advanced directive that somebody brings in and says, my mom would not have wanted this. And then a sibling comes in and says, yes, she would have. What are you talking about? And now there's this fight at the bedside of, should we continue? Do we not continue? She wouldn't have want this. Yes, she would have. Do everything. And that kind of family conflict is kind of puts us in a very difficult position, especially because, like I said, CPR is not benign. This is something that's, number one, in elderly people does not have a very high success rate. So we know that what we're doing is oftentimes very medically futile, but we're doing it. We're giving it our all because we always do. We can, and sometimes things happen, but not very often. So having family members that are all on board is very much a relief for us, because we know that we're taking care of this whole person, right? We're not just trying to restart their heart so that they can have a beating heart inside a body with no brain activity,
Right. Right.
which doesn't feel good. That's not a good thing for us to feel like we're doing. But being able to say, you know, we're following this person's wishes, we're giving them comfort care at the end of life, we're able to, you know, if we do get their heart started again, but the family says this is not what they would have wanted, be on a ventilator, being able to give medications for end of life comfort to decrease anxiety, to decrease pain, and then having a meaningful discussion maybe with chaplains and like making this a meaningful end of life experience for the family is very fulfilling.
And I suppose that if you had a medical power of attorney present, I mean, that person, if the other person's unconscious, that person's word is correct, right?
Yes, correct.
Okay.
There are situations where the medical power of attorney is on the phone and
Ah.
the brother or sister or
Huh.
whoever who is disagreeing with them is at the
Yeah.
bedside, and that still comes up. So they're really, the best thing you guys can do is get all of your family members all on the same page about what you want.
Okay. Laura, you had a question?
Yes, thank you. Um, I had some technological issues, so it's a little late, so I missed the beginning. And
We're
if you said,
recording it, Laura, so
okay,
yeah,
thank you.
right.
We will probably want to look at that. I've had some conversations in our family about this. My husband has a terminal illness, and my mother just passed away. So my understanding is that if you call 911 and the paramedics come to the house, they're automatically going to start with all life-saving procedures. Is that correct?
Not if we're presented with the paperwork right away. And if there's a family member there that will explain this, if they have the paperwork. And there's also a factor of whether or not, if the person was down for a really long time and their heart wasn't beating and there was no chance for us to get the heart beating again, like we'd see signs of death, we wouldn't do anything.
Okay. All right.
Yeah, Laura, so earlier Tom had explained that they do look for a POLST.
Okay.
Yeah, in that situation.
Yeah, I
Yeah.
talked to somebody whose parent is at Kendall at Ithaca, and she said in almost every apartment there's one of these documents on the refrigerator.
That's amazing. I wish everybody had one that needs one. I mean, I don't mean everybody needs one, but we need to have these conversations and have them readily available. I've also had conversations with people where they had it, they don't know where it's at. It's in a drawer somewhere, or it's at my sister's house, it's in a safety deposit box. Well, I kind of need that paperwork.
Yeah.
Great. All right.
Thank you very much.
Yeah, Erica, do you want to move on now, or do you have anything else that you want to share?
I'm happy to answer any other questions if anybody has anything for me, but other than that, I will let Dr. D'Souza do her piece.
Great. Let's see. Any questions, folks? Okay, this has been fantastic. Thank you both. Dr. D'Souza, please.
Great. For anyone who missed the introductions at the beginning, I'm a geriatrician. So I specialize in the care of older adults, opposite end of the spectrum from a pediatrician. Some people haven't heard of a geriatrician before, but I am passionate about this topic. And I'm going to share my screen again and pick up where I left off. Speaking to some of the questions about the effectiveness, and I'd really like to hone in a little bit more on, who should be completing a POLST and when. So many thanks to Erica for illuminating statistics about survival of out-of-hospital CER in older adults in general. I want to further highlight the impact of a condition called frailty. Frailty is it's a very strong principle. It's a very strongly known entity in geriatrics, but it's not something we really talk about a whole lot clinically with patients, this concept. And I'll talk about that on the next slide. What exactly is it? But, I think we all have a sense of frailty when we see it. And honestly, that's a little bit how geriatricians think of it as well. But survival to discharge is around 1% to 2% in severely frail patients versus 15% to 20% in their non-frail peers. And aside from the mortality, there are also worse neurological outcomes and impacts on quality of life, which I'll talk more about.
I apologize, Dr. D'Souza. Do you mind if I just elucidate something really quick? I forgot to
Go ahead.
So the amount of time that you are undergoing CPR is directly correlated with how much brain tissue you're losing over the course of that resuscitation. So your brain cannot get oxygen well during CPR as much as we really try. It's something like 8% of what a normal cardiac output is. So what we're really trying to do is specifically perfuse just the brain and the heart and hope everything else kind of comes back on board. But it typically means that your brain is without oxygen for a long amount of time. And that's associated with obviously losing a lot of brain tissue very quickly, leading to neurologic outcomes that can mimic things like coma or permanent vegetative states, or just a loss of significant brain and function, just overall function.
Thanks, Erica. So this diagram illustrates some trajectories in contrasting healthy people with frailty. And basically it affects our resilience, our response to stressors. Healthy individuals are able to bounce back, to return to baseline, whereas individuals with a mild level of frailty, they bounce back somewhat, but not to baseline. And in the case of severe frailty, undergoing a significant stressor implies that the outcome will be one in which they are absolutely dependent following something like resuscitation from CPR if it's successful, or just undergoing aggressive medical treatment. So that's a little bit of a visual to help people think about frailty. And what are the indicators of frailty? So this infographic and this list that I've compiled sheds some light on what are some factors that suggest that an individual may in fact have frailty. Fatigue or exhaustion, weight loss, mobility and balance impairment, incontinence, social isolation is contributory. Depression can actually contribute to frailty as well, and impairment in being able to carry out one's activities of daily living, like feeding, dressing, or bathing oneself. So if someone has even just a couple of items on this list, that portends poorer outcomes. Now I'd like to speak a little bit about and by the way, anyone feel free to interrupt with questions. My view is such that I don't think I'll see if a hand goes up, so feel free to chime in. The benefits of completing a POLST form, tremendous. The process of completing a POLST form in and of itself is an opportunity for folks to consider and discuss with loved ones what matters most to you. We talk about that a lot in geriatrics, what matters most. Not just, life prolongation, but functional outcomes, independence, those kinds of things, meaningful engagement with loved ones. So going through the process of completing a POLST form can be a valuable experience to really bring some of those values into focus. And the POLST form, as I'll go through in a little bit here, it actually provides a framework for considering various scenarios and options that I don't think exists anywhere else. We think about what preferences we have around CPR when when there's a cardiac arrest, but there's more to the POLST form. We've been talking a lot about CPR and attempts at resuscitation thus far, I'm going to illuminate some of the other important components of the POLST form that speak to just the intensity of care that individuals might want for themselves if they're in different situations, like someone mentioned a little bit ago, well, what if I was, in an accident and quadriplegic? What about then? Because that's not exactly, I think I misspoke when Rich asked and clarified, well, would the advanced directive apply then? And not really. An advanced directive applies when someone is, imminently dying. But there's a whole vast gray area that an advanced directive does not speak to, which is what about when you start to develop some degree of functional impairment and chronic illness. There's really there's no guidance apart from a POLST form. So it provides a framework for different pathways of care. And as we've been talking about, as Tom and Erica mentioned, the importance of talking to loved ones, it is a gift to your loved ones for them to know your values and preferences. It tremendously relieves them of stress, uncertainty, guilt, honestly, guilt, lifelong trauma, lifelong family discord that can occur from the types of situations that Erica outlined. So there's, generational impact, not to be too dramatic, but it really is, if nothing else, a tremendous gift to your loved ones to be able to convey with your own voice what your values and preferences might be in different situations. So the steps for implementing a POLST or a DEMOS, this comes directly from the polst.org website. But if you're starting to think, well, hey, how do I go about doing this? Initiating the conversation with a healthcare professional, primary care physicians can absolutely do this. I will say it's highly underutilized. I do come across primary care physicians who haven't necessarily heard of POLST forms. So it's variable. And then completing the form, filling it out with a clinician. And then the form needs to be signed by both the patient or their surrogate and the physician or other healthcare provider like a nurse practitioner or PA. And then there's the distribute step, which Tom and Erica have also been talking about. Keeping that original in a safe place, like on the fridge or at the bedside, and sharing copies with family and medical providers. Someone asked, are these kept at the hospital? Absolutely, there are initiatives to try to have these forms on file. So whenever I complete them with patients, I fax them to the primary care physician. I fax them to the hospital system. Large hospital systems do tend to keep them on file, which is not helpful in the field, but it is helpful when someone reaches the emergency department. I also have people make photocopies and put them in their wallets. It's a little bit of a gray area about whether EMS can honor a photocopied version, and maybe Tom can speak to that. In my experience, they do. Tom, do you want to chime in about that at all?
Yeah, they do. Like I said, there's very minimal black and white in our industry. And like, if you have the support of your family and things like that, like 99% of paramedics and things like that will agree to honor a photocopy. We'll just have to call the doctor and paint a picture, and they'll 95% of the time will follow it too. Just like people in these situations, when you talk about frail and that's one of the things we would bring up to the doctors and help us make those decisions.
Thank you. Yeah, and when everything's cohesive, it makes this a lot easier on everyone involved. So again, this is the image I showed earlier at the beginning of the presentation about what the forms looked like. They're very similar. There are some differences, but basically they're the same. It's just how they're formatted and so forth. And this pink is the pink that we print them on. We print them on this bright pink cardstock. That's sort of the standard across the country, so that EMS knows to look for this pink document or a pink envelope. And yeah, keeping it on the fridge or at the bedside. So there are typically these 5-ish sections on the POLST form. I'm gonna speak from the Delaware version, which is slightly a different order from Pennsylvania, but the DMOST is the one that I'm most familiar with. I do go through POLSTs with my Pennsylvania patients, but um, I like actually how the Delaware form starts with goals of care in section A, which many people leave blank, but I tend to think of it as the most important, one of the most important parts of the form, because it's an opportunity to illuminate and to elaborate on what matters most to you as a person. We can't predict the myriad emergent situations that could happen, but completing this goals of care blurb enables family and clinicians to have sort of a lens through which to interpret any given situation. If we say, so and so was very clear that what matters most to them is being independent, being able to perform their personal care independently, and to be able to have meaningful engagement with their loved ones, or to really appreciate physical affection and touch. And in this particular scenario, the treatment options that are being offered might keep them alive, but would not necessarily behoove their goals of being independent in personal care and so forth. Then it might be a lot easier to make a decision and say, you know what, I don't think they would want whatever options are being offered if there's a high likelihood that those goals of care won't be honored. And this is a tool that I use to generate the content of that section A with my patients. It's called the What Matters Most structured tool. And there's 3 columns here: functioning, enjoying life, connecting. And you circle, all of these things are important to all of us, but you circle the top 3 in each column that are really critical to you as an individual and your quality of life and what gives you the most meaning. And then from there, you pick the top 3 overall, and it's a very effective exercise. So this is a conversation that's very, very helpful. Stepping back from the medicalese of CPR, ventilation, having this conversation is so valuable about really talking about who the person is and what's important to them. So then in section B on the DMOST form, or section A on the Pennsylvania form, that's where you indicate a preference for or against attempts at resuscitation. And this is where I typically, and I do this, by the way, as a family meeting as often as possible. And I try to remote in important family members who can't be there in person. We really go to great lengths to arrange this meeting, particularly not just the primary healthcare power of attorney, but definitely any alternative backup powers of attorney on the form, and other family members that are just important to include as a matter of course, so that everyone's on the same page. And people say this is a difficult conversation, but they tend to be so grateful on the other side of things that this conversation was had. I'm jumping around a little bit, but when they are faced with these situations, they're able to say, "Oh, thank God I had this conversation. We had this conversation with Dr. D'Souza. I wasn't," because you're a deer in the headlights when it's actually happening, and the opportunity to give thoughtful consideration to these things ahead of time is really very helpful. So yeah, at this stage in the conversation, I'll outline what Tom and Erica just talked about. Dispelling the myths about what we see in the media and what people think CPR consists of, where you just shock someone and they wake up. Nope. And really illuminating that. And then talking about the impact of frailty in particular. And people say, wow, I had no idea. I wouldn't necessarily make the same choices now that I have this information. I want to spend more time now on section C. This is
Dr.
something
D'Souza,
Yeah.
just one quick question. People are interested in getting copies of What Matters Most. Is that possible?
Absolutely. I can email it to you, and
Sure.
you can distribute it.
Yep, that'll be fine. We'll do that. Great.
Sure. So section C on the DMOST form and section B on the POLST form speaks to the scope of treatment of medical interventions that someone would want. This section is not as critical to have completed ahead of time, in that the treating providers will be having conversations in real time with the medical power of attorney if the person can't speak for themselves. But it is nonetheless super important and helpful, again, as a vehicle for discussion, kind of a thought exercise to think through the implications of these options ahead of time. And again, just to reiterate that this form is critical to have in place if a person's preference for resuscitation attempts is do not resuscitate, so that can be honored in the field. The FAQs for these forms, by the way, typically say that they recommend it to be completed for anyone with a life expectancy of less than a year. I complete this form with all of my patients. By definition, I treat people with cognitive impairment and dementia, but really anybody, again, with any of these signs of frailty. It's never too early to have this conversation and to really think about this section about medical interventions and scope of treatment, for example. So there are, were you about to say something, Erica?
Yeah, can I just add really quick to, I mean, like you said, you do it with all your patients, possibly years before they pass away. So I think it's really important to also remember to continue to have these conversations as your loved ones or your own healthcare starts to evolve and change, and your ideas about what you would want for the end of your life also continue to change.
Absolutely. Excellent point. I revisit this conversation annually and sooner if there's been a change in condition. So if somebody does have an unexpected health event that causes a change in their condition, I will absolutely proactively bring it up and say, hey, I think we should talk about goals of care again. So the medical interventions, this is relevant to when someone is breathing and has a pulse, but they are ill. So there are three broad pathways, if you will. These aren't formal pathways, these are just conceptual pathways. But on one end of the spectrum, there's full treatment. Do everything that modern medicine has to offer to prolong life and keep someone alive. Intensive care unit, mechanical ventilations, invasive surgeries, chemotherapy, dialysis, all of those things. On the other end of the spectrum is comfort care, treatment of symptoms only, purely palliation, not trying to reverse or cure anything that arises, but really the goal being to keep someone comfortable. So in between those is a vast area, gray area of a very heterogeneous area of different scenarios, which I liked the language from the POLST website. Rather than limited treatment, I think selective treatment is a better terminology, which is acknowledging that as someone develops some degree of frailty, that they may not want to avail themselves of everything that modern medicine has to offer, because it may leave them with significant functional impairment, much like the outcomes of surviving CPR. And when I forgot to kind of discuss in section B, what are the outcomes and what are the implications of surviving CPR? Erica began to allude to this, that if someone survives it, there are a whole host of outcomes. We don't know what degree of neurologic injury might have happened from lack of oxygen to the brain. Typically, we won't know that for at least a few days. People are transferred from the ER to the ICU, and they're typically in the medically induced coma for at least a few days while the underlying cause of what's going on is being sorted out, trying to figure out, was it an underlying sepsis? Was there an infection, a pneumonia, or a urinary tract infection that developed that needs to be treated? Was there a cardiac event? Was there a blood clot to the lungs? And assessing all of those things. Were there electrolyte or metabolic disturbances? So trying to figure that out and initiate treatment. So it's a few days before, most of the time, we're able to reverse the sedation and assess someone's neurologic outcomes. Meanwhile, people are heavily drugged to tolerate this process. You require that sedation just to tolerate having a tube down your throat, etc. Bedridden, bedbound for days without any movement, that will lead to a great deal of deconditioning, loss of physical strength. A lot of times there's delirium developing, which is, acute confusional state. And at the end of the day, many, if not most people who survive CPR, they're not being discharged home. They typically require transfer to a rehab facility for further recovery. And when there's frailty at play, depending on the degree of frailty, people may not return home ever. Even if they survive an event like this, they may be looking at living in a nursing home, being dependent for care, and that may be fine with some people. It depends on individual preferences and also the neurologic pictures. Some people would say, well, yeah, if I'm with it and I can communicate with my loved ones, I wouldn't necessarily mind being in a rehab or nursing facility for long-term care. Whereas for others, again, independence with personal care is a huge deal. And they say if there's a significant likelihood that I might end up not being able to come home and live my life the way I do now, I don't want to go down that road. And so I mention all that in parallel with this full treatment option. The same mentality or the same thought process applies, when someone undergoes attempts at resuscitation as when they're undergoing ICU treatment. It may have similar outcomes that leave a person, it may prolong their life, but the end result may be a decrease in their quality of life, their ability to function independently, to engage with loved ones, etc. So back to talking about this selective or limited treatment option. That's when people say, yeah, of course, I want treatment, but I don't think I want the kitchen sink. And there's a lot of variability. Again, we can't predict different scenarios. I try to give a vignette at this point, an example. Let's take an example of someone developing pneumonia at home. So if you develop pneumonia as an outpatient, you typically, go see your doctor, get started on antibiotics, and hopefully that turns things around. There's fever, there's shortness of breath, coughing, those types of symptoms. Hopefully you get better. If not, the next step is going to the emergency room if those treatments are not working. And most people, so in this limited treatment situation, there are some people that already have hospice set up and they say, I don't want to go to the hospital. And their plan of care is to have hospice arrangements. But if not, going to the hospital and getting treatments like IV antibiotics, oxygen by face mask, more powerful treatments. And so many people would say, well, I want all that. I want to try to get through the pneumonia and get the pneumonia reversed. But I don't think I would want the ICU and breathing machines if I get worse. Again, because of the likelihood that undergoing that pathway might lead to a decrease in their quality of life ultimately. Yeah, that's sort of an example of how that limited treatment option might play out. I'm just trying to look at the time and make sure that I'll try to move things along. But does anyone have questions about the treatment pathways, the medical interventions or scope of treatment? And so these are not set in stone. That's the other thing to clarify. None of these are set in stone.
I
Again,
do
and
have a question. I
please.
don't mean to interrupt. Hi, this is
Oh,
Jane.
please.
I'm sorry, tech trouble here. I don't know if you can see me or not, but
I can't.
this has been very helpful. I appreciate this very much. This kind of form, I have a question. I could see myself drawing, and I could see patients drawing a line and putting other little statements in there, clarifying pieces. When we're dealing with these forms, will those little clarifying pieces that the engineer types are going to write in, will they be respected as well, or do people really need to stay with the form and keep it cut and dry?
It's an
Have you
excellent.
experience with that?
Yeah, absolutely. And I think it depends on the nature of the annotations, if you will.
Mhm.
So one common one, there's a couple of common ones that I help people to include. One common one here in C about medical interventions. Oftentimes people might say, yes, limited treatment, meaning I do want hospitalization, or for my loved one, I do want hospitalization and attempts to reverse the condition. But, and this is the annotation, low threshold to transition to comfort care if treatment is not looking good.
Oh,
And so
that's beautiful.
that's really helpful to the people on the other end to set the stage, and for the family, they want a chance, but they very low threshold to transition to comfort care. So that's one annotation. Another one in section D here, which we haven't really talked about. I don't think there's I don't think it's high yield to talk about this, but under artificially administered fluids and nutrition. Um, Many people will say, no, I definitely don't want, life support type of artificial nutrition and hydration, but I do want to clarify that I would want IV fluids in the course of usual treatment. I think that's a given, but sometimes it helps people to be able to articulate that on the form. And I write out, yes, this person would want IV fluids in the course of usual medical treatment rather than just for life prolongation, if that makes sense. So, yeah, reasonable annotations absolutely are honored and are helpful.
Okay, thank you.
Yeah, absolutely. Um, sometimes people will try to say, well, I want chest compressions, but not a breathing tube. And that gets really messy because that's not how CPR is intended to be performed. And I don't know if Erica or Tom want to chime in about those types of situations, but it doesn't make a whole lot of logical sense as the medical provider.
Yeah, I was actually just about to say, we as medical providers, we want to honor your wishes, but each person's medical journey, or each person's their situation is so nuanced and so different that there's absolutely no way that you can put in every scenario, this is exactly what I want. So I think the annotations, like, I really like that low threshold to transfer to comfort care annotation. I think that's amazing. But I think the most important thing is probably going back to that what matters most to you conversation, and making sure that your family is very, or whoever would be making these decisions on your behalf, knows the core of what you want, so that all of the decisions with the medical team can be made with those in mind, rather than just kind of like a yes or no in any situation, based on the DMOST form.
Absolutely. Again, and that's why I think this goals of care section is so important. And just writing a couple of sentences in tiny letters about what's important to that person, it really provides an orienting framework through which to make unexpected, myriad decisions. So let's see. Oh, I could have blown this up for y'all, but here it is, section C blown up, so you can read it better. Here's the what matters most again, and I think I'm just going to wrap up before more Q&A with my key points, which are number one, that for frail individuals, survival and quality of life outcomes of CPR and aggressive treatments are poor. Number two, POLST and DMOST forms are needed to honor a DNR preference in the community outside of healthcare settings. And finally, POLST and DMOST forms are an extremely valuable tool for understanding and specifying treatment options and pathways as health status changes. I think I meant to say towards the end of life. So here are some websites, the National POLST Collaborative, and direct links to the POLST and DMOST forms. I'll also send the What Matters Most PDF to Rich, and that's my contact information. And then I do need to make one shameless plug for I wanted just to let folks know, if you know a family caregiver of somebody with Alzheimer's or another dementia who is really struggling to cope with their caregiving situation, I wanted to let you know that my my organization, Compass Dementia Care, offers a 7-week Savvy Caregiver skills training group support class, both in person or virtually. So anyone anywhere can take the virtual option, and our spring session starts on April 15th. The course is phenomenal. It's taught by a very skilled and knowledgeable LCSW on my team. And past participants have said the course has been really life-changing to orient them and give them tools to better understand dementia and their loved ones' progression through it, how to manage challenging behavioral symptoms, how to take care of themselves, and more. So thank you very much.
Great, great. Dr. D'Souza, that's got to be one of the better shameless plugs I've encountered in a long time. So thank you. This has been
Absolutely.
wonderful. Erica, Tom, and Dr. D'Souza, you provided a valuable service to us all. I'm pretty sure what we can do is on our website in the next couple of days, take these, maybe get a collection of PDFs and links and put them up there. And our coordinator will send out to everybody who, got this link for this presentation. So with that URL.
Could,
Any
are we
other
going into
questions?
queue? Yes, please.
Yeah, well, sure. We've got only a few more minutes, but because people have been asking questions, Jane, as we rode along. But please do. You asked a nice question before.
One more that might be helpful to people is over the years, I frequently saw families that were notified that their loved one is actively dying. Could someone please speak to what's going on, what it looks like, and what decisions, if any, need to be made when someone is actively dying? Please.
That almost sounds like a hospice question, but Dr. D'Souza, do you have any?
I'm trying to understand the scenario you're talking about.
Skilled nursing facility where a family member,
Okay.
they're deteriorating, and
Yeah.
medical and nursing have determined that they describe it as actively dying.
I think, ideally these conversations would have already taken place. If they haven't, I think the key thing to know there, again, I would say there are some nursing home residents that don't fit this description, but the vast majority are not going to have a positive outcome. The nursing home is required to make that call. And the best advice I can give is that probably the best, most compassionate answer is to please make my loved one comfortable, not the knee jerk, because the nursing home is going to be saying, should we call 911? Should we send them to the ER? And that's what they're required to do, because they have to ask a power of attorney what to do. And it really is kind of, ideal that these types of conversations would have been discussed ahead of time. There is a such thing as a do not hospitalize order that can be in the nursing home residence chart, where they don't, they are very intentional about caring for them and providing palliation of symptoms in the nursing home, and they don't even have to make that type of a call. But I hope that kind of answers your question.
Thank
Well,
you.
I think Jane may have been referring to, I mean, a situation where hospice care workers understand that a person is near death. I know when my mom was in hospice, they sent out word, and we all gathered because there were signs
Okay.
that,
Got it. Yeah, that's another scenario.
yeah,
Absolutely. When hospice is involved and they're giving family the heads up, hey, it looks like it might be time.
right.
Many people said, but what's that?
What
What's
is,
If
hospice?
someone walks in and says they're actively dying and walks back out, and the family are looking at each other and saying, "What's that? What's going on?" Yeah.
Mm-hmm. Mm-hmm.
Okay. Thank you.
yeah, I
Sure.
think there it's good to be involved with a very reputable and caring hospice organization. 'Cause,
Mhm.
yeah. Any other questions, friends? So,
Christine?
yep.
Um, the actively dying piece, because I remember this from my mother who had hospice and died at home, but I saw it in the hospital also. There are color changes, there are skin changes,
Mhm.
there are breathing changes. There are things that happen at that last 24 hours, maybe a little bit less, that you just physiologically, you just know that things are coming to an end stage there. I don't know how else to say that, but
So to kind of piggyback on that, I think there is definitely an expertise when it comes to those dying moments. Similar to, like labor and delivery nurses or OBGYNs at the beginning of life, there's an expertise. Um, Similarly, there is an expertise when it comes to the end of life. And I think, like Rich mentioned, these hospice nurses, hospice professionals are exceptional and incredible individuals. And they kind of develop this like sixth sense for time frames when it comes to active dying. And I think it's obviously all the changes that Christine mentioned, but I think similarly it's more of just a sixth sense that they develop over the course of their careers. So again, I need to shamelessly plug hospice and say that I'm not the person to talk to about that because that's what we try to avoid in my line of work.
Mhm. Mhm.
So hopefully you guys have a discussion with some hospice care as well.
Well, if it's okay with everybody, I think it might be time to close. It's a couple minutes early, and I just want to share all of our appreciation to Dr. D'Souza and Tom Vogelsgang and Erica Sacchi. You guys were just wonderful, and uh, I mean, you've increased my appreciation of the whole medical profession. Just wonderful.
And I think I could speak for Doctor and Erica. We appreciate you guys having these conversations because this gets so much easier and to manage for everybody, for the medical providers, for the family, if we just have these conversations together and have these decisions already made.
Yeah,
Thank you. Thank you.
yeah, thank you very much. To
Thank
go
you.
back on what Tom was saying just for a second, I know there's been a lot more discussion in the general eye about moral distress among caregivers, especially after COVID. And a lot of these moral distress injuries on our end come from not having these conversations and come from the stressful situations of patients and families not understanding what we need to do or more importantly, what they want and what it truly looks like. So having those conversations on your end also helps translate to less distress, less moral injury, and better outcomes for us. So I really do appreciate everything that you guys are doing in educating yourselves.
Erica, that's a great way to end it. Thank you very much. And we'll end the recording there, Chris.